Hello, I'm Susan Cole, and I'm joined by
Dr. Vanessa Apea.
and welcome to Health and Power, the new monthly broadcast about the health inequalities affecting people of colour.
And we are absolutely delighted to be joined today by Professor Bola Owolabi and Professor Kevin Fenton. And I'm just going to tell you a bit about them. Professor Bola is the Director of the National Healthcare Inequalities Improvement Programme at NHS England. She works as a general practitioner in the Midlands region of England, and she's also an honorary professor at the Institute of Applied Health Research with the College of Medicine and Dentistry at the University of Birmingham. And Bola has a particular interest in reducing healthcare inequalities through integrated care models, service transformation, and really using data and insights for quality improvement. And she spearheaded NHS England's Core 20+5 approach to narrowing healthcare inequalities. And we're going to be looking forward to talking about that with her today. And then we also have Professor Fenton, who is a senior public health expert and epidemiologist and the regional director for London in the Office of Health Improvement and Disparities, and that's within the Department of Health and Social Care. He's also the statutory public health advisor to the Mayor of London and the Greater London Authority and the regional director of public health for NHS London. So he provides leadership across London for health and wellbeing, prevention of ill health, health protection and reduction of health inequalities.
It's absolutely amazing to have them both on and to be doing the show with you, Vanessa.
It is. I'm so excited. It's been the thing that's been pushing me through. Great start to the year.
Yeah, absolutely. And I think that COVID shone a light on health inequalities, but the reality is it's been devastating that the lives of people of colour for generations across so many different disease areas. So for instance, Black women who are giving birth are 4 times more likely to die in childbirth. Black and Asian women who have breast cancer are more likely to have a worse outcome, as are Black men who have cancer. And I mean, it's absolutely shocking. There's awful inequalities in relation to mental health. We're more likely to be sectioned, but less likely to be offered talking therapy. And I think that people are acutely aware of these types of inequalities, and it can stop people from coming forward in a timely way to get the care that they deserve. So I'm so glad that we're going to be talking about this.
No, definitely. And I think, as you said, everything that happened in COVID and these inequalities, it wasn't anything new. And people were feeling it. It was their lived experience of life. And they really were aware of how their health had been impacted by being Black, being of color. And I think that one of the things that's so important is that how do we, talk about it, make people aware, but also think about how we advocate for ourselves and also know what is happening already in society to improve things as well, and working together to change things. So I think that's what I'm really looking forward to really sharing, learning, and just bringing everyone together so that we can advocate as a community.
Absolutely, because I think knowledge is the most empowering thing for people. So shall we bring on Bola?
Zan and Vanessa, what a pleasure to be here with you both and with Professor Fenton. Just always so important to have the opportunity for this conversation. It's part of how we get to the answer and how we genuinely reduce the health inequalities gap. So thank you so much for the invitation and the opportunity to join the conversation today.
Well, it's absolutely wonderful to have you on. So, Bola, so you're Director of Health Inequalities for NHS England. So, why was a division created to focus specifically on health inequalities within the NHS?
I think I'll go back to the NHS long-term plan that was published in 2019. So actually pre-pandemic. And healthcare inequalities and health inequalities more broadly formed one of the strategic priorities identified in the NHS long-term plan. So there was a commitment to accelerating action to reduce health inequalities in the NHS long-term plan. However, what happened materially that brought forward the National Healthcare Inequalities Improvement Program was, of course, the pandemic. And I think as the data started to emerge, I think we go back perhaps to April 2020, when we first saw, the Public Health England's report, which started to show the disparity in terms of the likelihood of contracting the coronavirus and the severity of disease and the differential in mortality. And of course, Professor Fenton's report, Beyond the Data, which then came out in July of 2020, that really demonstrated for the first time the ethnicity dimension to that inequality. I think we began to see that, in the first wave, certainly, that a Black African man was 3.7 times more likely to die if they contracted the virus. And for Bangladeshi men in the second wave, it was 4-5 times more likely to die. And I think the data was so compelling that there was a collective realization that specific focus on tackling health inequalities was imperative. And so the 8 urgent actions were published. This is a piece of work that was led by Dr. Owen Williams, who is the current chief executive of the Northern Care Alliance, at the request of the then chief executive of NHS England, Simon Stevens. So a health inequalities oversight group was convened that came forward with the 8 urgent actions for tackling health inequalities. And that actually formed the foundation and the precursor to the program that I now lead, which came into being in January 2021. So I think it's really important that contextually we explain that there was a commitment pre-pandemic, but absolutely the pandemic accelerated the standing up of a bespoke program to lead in this area, and also the creation of the Health Inequalities Director role nationally.
Mm-hmm. Thank you. And do you think that there's an economic case as well as a moral case to address health inequalities?
I think if I reflect again on the inequalities that we experienced during the pandemic itself, and going before the pandemic, we had data, for example, around healthy life expectancy gap between the most deprived and the least deprived population. So we know pre-pandemic, we went into the pandemic with a healthy life expectancy gap, nearly 20 years difference between people, say, from the most deprived 20% of our population compared to the top 20%, 19.6 years to be precise, in terms of healthy life expectancy gap. And then when you think about the life expectancy gap itself, a woman from the most deprived communities compared to a woman from the least deprived communities, that then gets in the order of 10 years. And so that's the state in which we arrived in the pandemic. And I say that because it's important to clarify that the COVID pandemic did not cause health inequalities. What it did was exacerbate pre-existing health inequalities, and it thrust them into the public consciousness, perhaps in a way that hadn't happened before. And yes, there is a business case beyond a moral imperative. So if you consider that long-term conditions, they start a full decade earlier in some of our ethnic minority communities, type 2 diabetes, people from South Asian communities are 6 times more likely to develop type 2 diabetes over the course of a lifetime. And that type 2 diabetes tends to start 10 years earlier, which means people are accumulating the end organ damage from diabetes for 10 more years compared to the wider population. And what is the productivity implication of that? It means that long-term conditions, they start earlier, they accumulate faster, and they last longer. And with a social gradient and an ethnic minority disparity element to it. So people exit the workforce earlier, the tax revenue loss from that, the welfare benefit payout that then brings with it, and the loss of people's contribution to the community, the loss of community capital that comes from all of that, you begin to see how health inequalities translates to productivity inequalities. And that is the basis for my assertion that there is a business case for tackling health inequalities beyond the moral and ethical imperative.
Oh, thank you so much, Bola. You always put things so eloquently. And I think that health inequalities equals productivity inequalities. And I've seen that, you had that on Twitter as well. I love that. And I think it's great to hear your reasoning behind that, because that's exactly it. And I think one of the reasons why we wanted to do this broadcast was really to hear about the solutions and hear about the ways in which what's happening to address it. And it would be great to just hear about an area that's very close to your heart that I know, Core 20+5. So would you be able to tell us about that and just how that is part of your approach to tackling health inequalities?
Certainly. I think just a bit of a background before I come to Core 20+5 specifically. When I started in this role, I availed myself of the opportunity of talking to people right across the system, well beyond the NHS, in informal conversations, but also commissioned a report asking leaders in NHS England, in the NHS more widely, in local authority, in the voluntary care and community sector, asking the question, what can we do differently this time? Because, it isn't as though valiant efforts haven't been made over many, many decades to tackle health inequalities. And I wanted to understand from many voices what we could do differently this time. And what came out of that were a number of things. One is people were saying, you do need to focus. And when you focus, you get the opportunity of gaining traction and making demonstrable impact. And that for me was a very powerful theme coming out from all of those conversations. The other thing people said was, you need to understand very clearly your sphere of influence. So health inequalities are, of course, driven in the main by the social determinants: housing, education, household income, people's employment status. But it felt like there was a very clear message coming from people that those particular issues are perhaps in the leadership space of others. And your role is to contribute and influence that. But the thing that you can usefully directly impact are healthcare inequalities in terms of people's ability to access services, their experience of those services, and ultimately their outcomes. And I heard that very loud and clear repeatedly. And so we took that and began to look, okay, if we're going to address healthcare inequalities, whether the fact that, Black women and ethnic minority women are twice more likely to be diagnosed late with breast cancer or indeed ovarian cancer and other urogenital cancers. The fact that prostate cancer generally affects 1 in 8 men, but in Black men, that becomes 1 in 4. Or when you consider the COVID vaccination uptake rates and the fact that in the first wave, actually the uptake rate in the over 80s in the first wave was 82% overall, but 38% in Black Africans, 44% in Pakistani populations. That felt, from what people were saying, to be the sphere of influence we could directly influence. That was the origin of Core 20+5. So we looked at the data, we looked at the Commonwealth Global Burden of Disease Survey, we looked at Public Health England's Slope Index of Health Inequalities, the SCARF tool, and we triangulated the data, and it became apparent that that 20% most deprived population group by the index of multiple deprivation seemed to be the most affected, regardless of which condition you were looking at. And so that 20% most deprived by IMD became the core 20. The thing that also became apparent is that there were communities that don't even show up in the data. Like people experiencing homelessness or rough sleeping, and, significant proportions of ethnic minority populations, people in the asylum seeker system. And so we introduced the plus to try and capture them so that they didn't get lost. And that's how we ended up with the core 20 plus. And that same data set showed us that certain conditions were contributing mostly to premature mortality and or mortality disparities. And those were the 5 clinical conditions around cardiovascular disease, chronic respiratory disease, cancer, mental health, as you were referring to in your opening remarks, Vanessa, and it became apparent that these 5 clinical conditions were the biggest drivers. And that's how we ended up with Core 20+5 for adults. Of course, you will be aware that in November, we went live with Core 20+5 for children and young people, which includes asthma, oral health, epilepsy, mental health again, and you can see the cross-cutting theme there. So look, it's an approach. It's not all of it. It's a place to start. It's an excuse remover, that we can start somewhere.
That's wonderful. Thank you so much.
No, thank you. And I think, do you know what? I just love hearing the story in, the road to how you develop that. And I think that's really important for people to share and hear about. So thank you so much.
Thank you so much, Bola. Hopefully we will be hearing from you again soon.
Thank you so much. And thank you for having me.
Oh, it's been lovely. Thank you.
A joy. So I think we should be bringing on Kevin.
Hi, everybody. Hello, hello.
Hi, Kevin. Thank you so much for joining us.
Sure. It's a real pleasure to be here with you, and congratulations on the launch of your new broadcast, of your new podcast. And I'm so pleased that you're focusing on power and leadership today, because it's such a rich area to explore.
Wonderful.
Thank you. I know, and we're so excited to have you here. And I think you've given the perfect segue into what we wanted to ask first of all, from your perspective, about the power of local communities and really how they can be involved in shaping their environment to be healthier.
Yeah, it was so wonderful listening to Dr. Bola, because she really highlighted the importance of systems and organizations taking responsibility for prioritizing and addressing inequalities. But if we are going to make progress, it means that all of us need to be engaged in fighting for justice and in doing the right things. And in that respect, communities play an essential part in helping us both to understand inequalities, to address those inequalities, to find solutions that work for our communities, and to help to implement them. And that's exactly what we learned, for example, when we were going through the COVID pandemic, which was it was the engagement of local communities that enabled us to understand the power of language, the power of stories, the power of different channels that are needed for communities to engage and to trust, the importance of locations within communities which matter to people, whether it's their GP or their mosque or their church, and ways in which communities come together that really helped us to mobilize communities in COVID. So those lessons of community engagement remain as important and as powerful today.
Wonderful, thank you. And there's been quite a lot in the news recently about inequalities. I know the UN highlighted in the news, a representative suggested that the UK was institutionally racist. Why do you think it's important to have conversations about racism in relation to health outcomes?
You know, it's so important because we have seen where structural racism, these are the systems and the power structures which are in place, which differentially or preferentially value one race or over another, can have a detrimental impact on an individual's life course, an individual's chances, and it results in privilege to some groups and disadvantage to other groups. Now, we have over time understood the importance of education, the importance of the economic background that you have, the importance of other structural or social factors in determining health outcomes. But only recently have we begun to speak about the importance of structural racism and how that influences outcomes. And as you heard from Dr. Bola, those experiences and outcomes can influence how people trust the healthcare system, how they access the healthcare system, how they're treated when they are in the healthcare system, and the outcomes that they achieve as a result of going through the healthcare system. And unless we are explicit in calling out and showing through evidence the impact of racism on those outcomes and experiences, then it means that we won't be able to tackle them effectively. And that is why having these honest conversations and sometimes difficult conversations about the impact of racism is so important in tackling racial and ethnic disparities in health.
Thanks so much, Kevin. And I think you've just highlighted something I really wanted to ask you in terms of they are uncomfortable conversations when we have to name racism within health. And just particularly in your leadership role, how do you navigate those conversations about racism in health?
So, you know, as a public health director for the city, it's really important that everything I do is based on evidence, right? So I speak to the evidence, and where the evidence doesn't exist, I work with academics, I work with communities to find that evidence, to understand the nature of that evidence, and then to make decisions on policies or programs as necessary. So in doing our work through the COVID pandemic, we did literally hundreds of town hall events where we engaged with communities to understand what were the barriers to the vaccine, what we might do to improve their access to services. And this issue of how communities felt came up repeatedly about their negative experiences of engaging with the health and care system. And for many communities, they were able to say, actually, the structures of structural racism means that we're not equal partners. We don't feel we're able to engage. That evidence enabled us to commission further research, to do other studies, which then allows me the data to say to healthcare providers, to policymakers, that in addition to improving access to services, the times that services are open, the nature of the services that you provide, we also need to begin thinking about what works for tackling issues related to trust and confidence, discrimination and stigma, and of course, racism in services. And that's exactly what we do. So as a public health physician and practitioner, using evidence, using the data, and then having that inform our policy is really the best way to facilitate this. And again, engaging the community and generating that evidence is key.
Thank you, Kevin. And you raised the issue of trust, and the Windrush scandal is back in the news. And I'm really conscious that our elders from Caribbean communities have been through so much, and many of them have experienced healthcare inequalities and are understandably concerned about going into the hospital and, you know, the type of care that they're going to have. And many of us, like my mum is 88, and she was recently in hospital and she had fantastic care, but I was really scared about what was going to happen when she was going to go in there. And it was a real struggle to persuade her to go into hospital. What can we do to keep our elders safe?
Well, you know, this is again where understanding the sort of lived experiences of communities are so important in helping to shape and design services that meet their needs better. It also shows the power of storytelling and capturing the experiences and using it to inform people like myself who are designing services so that we can incorporate that into the ways in which we deliver the kinds of services that need to be delivered. The reality is, if people don't trust the services, if people are afraid, if people feel that there are barriers to access a service, then it is no surprise that they won't use a service or they won't take up an offer, even if it is in their best interest to do so. So the key lesson from this, and I think emerging from the pandemic, and this is what we're doing across London at the moment, is that we have to raise awareness about the nature of this issue. We have to acknowledge that trust and confidence is a big issue that influences how communities value and view services. We must work with communities to help to co-design and co-produce the sort of interventions that work for them and the services that work for them. And the key thing about building trust, and you heard me say this during the pandemic, it's a function of truth times consistency times time. So in addition to doing all these things, we must be consistent and remember that trust will be built only over time by doing things consistently. So I think all of those things have to be part of what we need to do, whether it's for HIV services, whether it's for mental health services, whether it's for the future of our COVID services. We have to invest time and consistency in doing what needs to be done.
Wonderful.
Thank you, Kevin. And it's great to hear the rationale and behind the work that you do as well. And we just were wondering just what drives you to do the work that you're doing to address health inequalities, your personal drivers as well.
So, you know, I started my public health career, as some of your listeners will know, nearly 30 years ago at the beginning of the HIV pandemic. And when I started, a lot of my early experiences as a young doctor was taking care of patients who were dying from HIV. And at that very formative stage in my career, I could see how that virus uncovered stigma and discrimination, how it disproportionately affected certain communities and certain sectors within our society, how it resulted in fear, and how that fear drove policy and how that policy had a material impact on people's lives. And even at that time, as a young person just starting in my medical career, I felt that I would use whatever voice I had, whatever power I had, whatever tools I had to be part of seeking and creating a more just world. And that started with responding to the HIV epidemic and research and clinical work and practice. But over time, developing the skills and the voice to be an advocate for tackling inequalities, not just for HIV and sexual health, but for all conditions, globally and here in the UK. So I think the passion and the commitment that I bring to the work is based on a commitment to evidence and science, a commitment to social justice, but also a commitment to doing the right thing because we know better.
Right, goodness.
I can't think of a better way to
what a wonderful way to end the last episode of the first episode
First.
of this series. Thank you so much, Kevin. That's so pertinent and so inspirational for all of us.
Great. Thank you so much. Congratulations again, and all the best for the series. I look forward to hearing and watching you in the future.
Thank you.
Thank you so much. Thank you. And I think we can only just say thank you together. Thank you to our wonderful guests, Bola and Kevin. You always have the perfect way of constructing and being so eloquent and just conveying what needs to be conveyed. And it was a real honor to have you both on today. So thank you so much.
Absolutely. And I'd like to thank Disruptive Live for their technical wizardry, actually putting all of this on for us, and no one has disappeared, which is always great. I'd like to thank the National Lottery for supporting this broadcast series. Thank you, Vanessa.
I'm going to say thank you, Susan.
And do please join us for the next episode of Health and Power on Monday, the 27th of February at 5:30. So we'll see you then. Thanks very much, everyone. Bye-bye.
Thank you. Good to see you. Bye-bye.